Good. No, thank you. That's really helpful. And thanks everybody for sending questions and I'm incorporating those into my question. Mark, one of the questions that's come in from the audience um, is there good evidence with fee for service that free market theory works in healthcare? Where's the evidence that competition has lowered cost in U.S. healthcare?
Well, the main evidence actually comes from studies of hospital mergers and acquisitions. And I always cheer for the home team, go Eagles. And I cheer for, in the four parts of the report, I cheer for this part because I think it's got the strongest empirical and theoretical evidence behind it. And the punchline is when hospitals combine, prices go up on the order of somewhere between 10 and 20%, about the same order of magnitude as you were talking with David Cutler about on the administrative costs. So at least in terms of evidence that competition works to lower prices, have prices be lower than they would be in the absence of competition. I think that's pretty much indisputable, although you can dispute anything. In terms of the growth of spending, it's a little more ambiguous because that's a separate category, and sometimes spending should grow, but I think there certainly is evidence in the hospital sector. I think that pretty well answers the
Mark.
question. Of course, nothing in life is ever perfect, and competition cannot be. We economists don't give guarantees. I don't know, maybe surgeons do, but I think not. That it'll always work, but as I said earlier, more often than not, in my impression, markets where there's competition have lower prices and also lower rates of growth in prices.
Mark, a quick follow-up question from the audience. Since there are obvious benefits of large hospital systems, for example, health IT investments, cyber defense,
yep,
so forth, isn't it better to have price caps and price growth caps instead of Don Quixote breaking up? You were asked today.
Well, I'm not sure which is Don Quixote. Price caps may not be so. I mean, they would not be so easy in Indiana and Idaho. Let me say. However easy they might be in Massachusetts and Maryland. So political feasibility, obviously, I'm not the expert on, but I think it's probably not guaranteed here. But the other point is, for those, of course, the hospitals that merge always say, we are going to achieve economies of scale, greater efficiency, higher quality, and so forth. Along with my colleague, Rob Burns, we've studied that over and over and over. We have a new paper coming out of the Milbank Quarterly that says, has things changed in the last 10 years? And the punchline seems to be, on average, no. Hospital mergers do not improve quality. They don't make better use of new technology. That's an average, of course. And of course, the hospitals that want to merge always claim they're going to be above average, the sort of Lake Wobegon theory of hospital merger. But we don't really, that's not really a good thing to bet on. Plus, most of those technological things you can rent. You don't have to own them in your own system, particularly if the kind of standardization that was talked about in the previous session is put in place. And I guess the third thing to say is that the proof that those kinds of systems really do that much good, we're still waiting for it. It sounds like a good idea. That's a chance for me to make a commercial. I just put out a book about healthcare management and innovation called It Sounded Like a Good Idea that people might want to look at. And we looked at IT and we ended up saying what I just said. I didn't write that chapter, some experts did, but that it's one of these things in healthcare, whether it's IT or whether it's value-based payment, where the promise is always in the future. and doesn't seem to ever materialize in my lifetime. So
good. Thank you.